Imagine you have a patient whose chest cavity has, well, literally just stopped growing.
Yeah, it's a terrifying scenario. By adulthood, their rib cage is essentially this rigid, ossified shell.
Right, and it's actively suffocating their own heart and the lungs.
Yeah.
And, you can't just stretch the bones with medication.
No, absolutely not. You have to functionally break the entire rib cage, expand that intrathoracic volume, and then rebuild the whole architecture with titanium.
Which is just wild to think about.
Hmm.
So today we're looking at what happens when textbook thoracic surgery completely fails to capture the reality of the operating room.
Exactly. It's the clinical definition of navigating surgical muddy waters. Because, textbooks provide you with perfectly color-coded anatomy and these standardized algorithms.
Yeah, the idealized version of the body.
Right. But under the lights of the OR, you are dealing with altered biomechanics, dense adhesions, and dynamic physiological systems that, frankly, actively fight against your surgical plan.
And that is exactly why the medical students, the surgical residents, the young professionals tuning in today need to stick with us for this one.
It's going to be a fascinating discussion.
Yeah. The mission of today's deep dive is to extract the most crucial clinical lessons from an absolute masterclass in surgical problem solving. We are analyzing the medical text Thoracic Surgery, 50 challenging cases, edited by Wiki-T Vigneous Winen.
It's an incredible compilation.
It really is.
Yeah.
And we are going to look at the mechanics behind these procedures. So not just what was done, but why it worked.
And I think the foundational philosophy of this text is laid out right in the preface. It sets a pretty sobering tone for our discussion today.
Oh, for sure.
It basically says that surgical morbidity and mortality are the direct results of incorrect decisions. Success here is rarely just about your manual dexterity or how well you throw a stitch.
Right. It's not just about having good hands.
Exactly. It's entirely about clinical adaptability, rigorous patient selection, and recognizing when a standard approach is just going to be lethal.
Okay, let's unpack this. Let's jump straight into the literal architecture of the thoracic cavity, starting with the rigid outer boundaries, so the ribs and the sternum.
A great place to start.
Historically, the standard for resecting a chest wall tumor was a highly morbid open thoracotomy, right? Like the traditional logic was that wide local excision and reconstruction for any defect greater than 5 centimeters just meant massive incisions.
Yeah, and those massive incisions profoundly altered the patient's respiratory mechanics.
Because of the pain, right?
Precisely. The perioperative pain from a massive open thoracotomy severely limits the patient's ability to breathe deeply or clear secretions. And that is a direct pipeline to postoperative atelectasis and pneumonia.
Which is exactly what we want to avoid. But the text details this massive paradigm shift. Take case 1, for example. We have a patient suffering from massive fibrous dysplasia on the 3rd and 10th ribs.
Right, so traditionally that's a huge open surgery.
But instead of filleting the chest open to ensure negative margins, the surgical team utilized a robotic-assisted VATS approach. That's video-assisted thoracoscopic surgery.
Which is a brilliant application of the technology.
But here's where I really need to understand the mechanics. They use bipolar and unipolar electrocautery to dissect the intercostal space, right?
Right.
And they use dentist rib shears internally to divide the ribs. But they are dealing with a massive bone tumor, and they are using like a 3-centimeter working port.
Yeah, it sounds impossible on paper.
Right. How do you physically get a massive rigid tumor out of a 3-centimeter incision without defeating the entire purpose of a minimally invasive approach?
So it really comes down to manipulating the natural elasticity of the surrounding soft tissue and also just careful spatial orientation.
Okay, walk me through that.
Well, once the unblocked resection is complete, the surgical team places the massive tumor into a high-strength polyurethane endobag while it's still inside the chest cavity.
Oh, so they bag it internally.
Exactly. This isolates the specimen to prevent any microscopic seeding of tumor cells along the chest wall during extraction. You don't want to drag a naked tumor through clean tissue.
That makes total sense.
Then, instead of using a rib spreader, which is what causes that severe neuropathic pain we desperately want to avoid, they orient the bagged specimen longitudinally.
Like turning it sideways.
Yeah, they essentially slide it out between the ribs like a ship in a bottle.
Huh.
If the rib spacing is exceptionally tight, they might subtly extend the soft tissue incision, but the critical biomechanical framework of the rib cage remains completely intact.
Wow. So you secure the oncologic margin without destroying the mechanical integrity of the respiratory pump.
That's the exact goal.
But what happens when the bone itself is the entire problem? because the text brings up case 3, and the underlying pathology there is just wild.
Oh, acquired thoracic dystrophy.
Yes, ATD in an adult following a failed childhood ravish procedure for pectus excavatum.
Yeah, that is a profoundly difficult case. When a patient undergoes an extensive resection of costal cartilages too early in childhood, it can actually arrest the growth of the chest wall.
So the chest just stops expanding.
Right. So the patient in case 3 presented with a severely restricted, non-pliable chest. It was characterized by dense malunion and ossification of the sternocostal junctions.
Which means the intrathoracic volume is so diminished that it causes severe restrictive lung disease and cardiac compression. The organs are literally running out of room.
Exactly.
So I have an analogy for this. It's like retrofitting an old, non-pliable house. You can't just knock down a load-bearing wall without a titanium support plan.
That is a perfect way to look at it.
So how do surgeons balance the need to massively expand a rigid cavity with the sheer mechanical necessity of the patient needing a functioning, pliable chest to actually breathe post-op?
What's fascinating here is that it requires an incredibly precise application of biomechanical engineering.
Like architectural surgery?
Truly. The primary goal is to physically increase the intrathoracic volume. And to achieve this, surgeons perform strategic osteotomies. So, making highly calculated bone cuts across the ossified sternum and ribs to mobilize that anterior chest wall.
They literally cut the shell open.
Yeah. And once the sternum is elevated to create the necessary space for the heart and lungs, they fix that new expanded volume into place using rigid titanium rib and sternal plating.
So they're essentially jacking up the ceiling of the chest cavity and installing titanium struts to keep it there.
That is an excellent way to visualize it. Then, to ensure adequate soft tissue coverage over the hardware, and obviously to prevent infection or erosion, they often rely on musculocutaneous flap.
Like moving a muscle over it.
Right, like a pectoralis major advancement. However, the text heavily emphasizes that the physiological toll of reconstructing the entire anterior rib cage is immense.
I can only imagine. The recovery must be brutal.
It is. These patients face considerable postoperative pain and prolonged ventilatory weaning. Careful patient selection is paramount here because the perioperative risk of this structural overhaul is staggering.
Which makes sense. And that reliance on structural integrity leads us directly into a situation where the problem isn't just architectural failure, but a dynamic pressure battle.
Ah, yes. Moving downward.
Exactly. We're moving from the rigid walls to the dynamic floor of the chest, the diaphragm. Now, fixing a hole in a muscle sounds straightforward until you remember the physics of the human torso.
Right, because the chest and abdomen are essentially two completely different pressure zones.
Yes. The chest cavity operates under negative pressure to facilitate lung expansion, while the abdominal cavity is under positive pressure.
And because of that pressure gradient, any structural defect in the diaphragm will immediately act with a vacuum. It actively pulls abdominal contents upward into the pleural space.
Which is terrifying. And case 12 provides a really stark visual of this. A patient presented with worsening shortness of breath 2 years after a right hepatic resection, so a liver surgery.
Right. And the imaging there was incredible.
The CT scan revealed a 6 by 5 centimeter central defect in the diaphragm. And through this iatrogenic hole, the major part of her small bowel and transverse colon had completely migrated into the right pleural space,
causing total right lung atelectasis.
Yeah, the lung was completely collapsed under the weight and pressure of the invading abdominal organs, just entirely squished.
And to complicate things, because her liver was cirrhotic from the prior disease, the tissue was highly friable, making the surgical repair exceptionally delicate.
So how did they fix it?
Well, the surgeons utilized a right muscle-sparing thoracotomy. The mechanism of repair here is critical. They had to systematically take down the dense adhesions between the bowel, lung, and chest wall.
Because everything was just stuck together.
Exactly. And then they had to gently reduce the viscera back down into the abdomen.
And with a 6 by 5 centimeter defect, primary closure, like just pulling the edges together with sutures, isn't an option, right? The tension would tear right through the muscle.
Oh, absolutely. It would fail immediately. They had to use a massive 20 by 15 centimeter Gore-Tex patch.
So they essentially built a synthetic floor.
Precisely. The patch acts as a prosthetic floor. It is secured with heavy polypropylene sutures, deeply anchored into the diaphragmatic remnants and the chest wall laterally,
Creating a barrier strong enough to contain the cirrhotic liver and the bowel against that constant upward pressure gradient.
Yeah, exactly. It's a heavy-duty open repair.
Now, I want to contrast this heavy-duty open repair with case 14, because this is where the philosophy of surgical decision-making really gets put to the test.
Case 14 is a great counterexample.
It's a late presentation of a post-traumatic diaphragmatic hernia, and the surgical team initially attempted a robotic approach.
They did try that first, yeah.
But, I have to push back here on the modern medical obsession with utilizing minimally invasive tech for absolutely everything. Here's where it gets really interesting.
Oh, I see where you're going.
Why force a robotic platform in a late-stage hernia where the anatomy is completely distorted?
Yeah.
I mean, sometimes minimally invasive is simply the wrong tool for the job.
Well, this raises an important question, but the initial preference for the robot is rooted in very sound clinical reasoning.
Okay, play devil's advocate for me.
The robotic platform offers three-dimensional, high-definition visualization and 7 degrees of instrument freedom. That is practically unmatched when you're dissecting complex adhesions deep in the diaphragmatic recess.
Fair enough.
Furthermore, if it's successful, it drastically reduces the immense postoperative pain associated with a thoracotomy, which allows the patient to extubate and recover much faster.
I understand the theoretical benefits, but look at the specific reality of case 14. The herniating contents, the bowel, omentum, and liver, they occupied the chest cavity all the way up to the apex.
Yeah, it was completely full.
The pleural space was entirely occupied by abdominal viscera.
And that spatial reality is exactly why the robotic approach was aborted. A robotic or VATS platform is entirely dependent on carbon dioxide insufflation to create a working environment.
Right, an artificial pneumothorax.
Yeah.
You need air in there to see and move.
Exactly. Without adequate pleural space to insufflate, there is zero room to maneuver. Trying to blindly manipulate rigid, powerful robotic instruments against delicate, pressurized bowel tissue.
Sounds like a recipe for disaster.
It carries an unacceptably high risk of catastrophic perforation.
So they positioned the patient in reverse Trendelenburg to try and use gravity to pull the bowel down, but the vacuum effect was just too strong, and those adhesions were too dense.
Right. And the clinical reasoning here is the ultimate lesson for our learners today. Adaptability means swallowing your pride, stepping away from the high-tech console, and safely performing a low lateral thoracotomy.
So just open them up.
Yes. Gaining direct, tactile access to the cavity allowed them to safely, manually reduce the bowel and repair the defect. Deciding to push forward with the robot in a non-existent pleural space would have led directly to severe surgical morbidity.
All right, so we've navigated the anatomical spatial constraints, the titanium reconstructions and the dynamic pressure gradients of the diaphragm. Let's transition to the systemic physiological roadblocks.
This is where things get really complex.
How do thoracic surgeons proceed when the patient's own cardiopulmonary dynamics explicitly dictate do not operate?
This takes us right to the boundaries of physiological tolerance. We're moving from structural repairs to strategically altering pulmonary mechanics.
Case 47 focuses on lung volume reduction surgery, or LVRS, for patients with severe emphysema. Now, for any medical student reading the classic literature, chronic hypercapnia, so a PaO2 of 45 millimeters of mercury or higher has historically been a strict, absolute contraindication for LVRS.
Right. That was the gold standard rule derived from the National Emphysema Treatment Trial, or NIT.
Because early studies demonstrated unacceptable mortality rates and prolonged ventilatory dependence for hypercapnic patients.
Exactly. The pathophysiology behind the rule was that a patient with a baseline PaSO2 over 45 already has a severely compromised respiratory drive.
And pretty much non-existent functional reserve.
Right. The trauma of general anesthesia, single lung ventilation, and resecting lung tissue was deemed basically unsurvivable.
So why did the team in case 47 blatantly break that rule? I mean, they took on a patient with global respiratory insufficiency, severe hyperinflation, and chronic hypercapnia. Why would you cut into a lung that is already failing to clear carbon dioxide?
Because they looked past the absolute blood gas numbers and analyzed the specific morphology of the disease. Emphysema is rarely uniform.
Okay, meaning it doesn't damage the lungs equally everywhere.
Exactly. This patient had highly specific heterogeneous target zones, specifically massive bullous emphysema predominantly in the right lower lobe. The pathophysiology here is critical. Those massive hyperinflated bullae are entirely dead space. They do not participate in gas exchange at all.
But they take up room.
Yes, they occupy massive intrathoracic volume, actively compressing whatever functional, healthy lung tissue remains.
There's essentially parasitic air balloons crushing the working alveoli.
That's a great way to put it. Furthermore, the massive hyperinflation forces the diaphragm into a chronically flattened position.
Which strips it of its mechanical advantage as the primary muscle of inspiration, right?
Precisely. So, by performing an apical LVRS utilizing a hockey stick-shaped resection, the surgeons contoured the resection along the anatomical shape of the lobe.
But wait, how does that specific shape actually help the hypercapnia?
Well, the hockey stick resection allows for maximum volume reduction of the most diseased, hyperinflated tissue while preserving the underlying architecture of the remaining lung.
So you're just scooping out the worst part.
Right. And by instantly removing that massive dead space, two physiological shifts occur immediately. First, the compressed, healthy, functional lung tissue is allowed to re-expand and participate in gas exchange, correcting the perfusion mismatch.
Oh, wow.
And secondly, the diaphragm is mechanically allowed to revert from a flattened state back to its normal dome shape, restoring the patient's natural respiratory mechanics.
And the clinical result was astounding. I mean, the surgery didn't just marginally help, it actually normalized their blood gases and significantly improved their FEV1.
It's a beautiful demonstration of physiological intervention.
It proves that if a patient has severe hyperinflation with obvious heterogeneous target zones, hypercapnia alone shouldn't automatically disqualify them. The absolute guidelines are evolving based on highly nuanced patient selection.
And that nuance brings us to arguably the most intense physiological puzzle in the entire text, case 50.
Oh, this one is unbelievable. We are presented with a cystic fibrosis patient who desperately requires a bilateral lung transplant. However, there are two massive systemic complications.
Right.
First, the patient has a patent foramen oval, a PFO, which is a persistent opening between the atria of the heart. More concerningly, they have complete occlusion of the superior vena cava.
Which is a nightmare scenario for a transplant team.
Just to set the context for our listeners, complete SVC occlusion is seen in about 9% of adult CF patients. It's the cumulative result of lifelong chronic indwelling venous catheters for IV antibiotics.
Compounded by years of chronic systemic inflammation.
Right, leading to massive thrombosis and fibrosis of the main venous return from the upper body. It's like trying to replace a car's engine, but the exhaust is blocked and the fuel lines are totally tangled. You have to fix the plumbing first.
If we connect this to the bigger picture, a bilateral lung transplant on its own is already a massive physiological insult characterized by immense hemodynamic shifts.
Yeah.
When you add complete SVC occlusion, the pathophysiology changes entirely. Over the years, the venous blood from the patient's upper body has found alternative routes back to the heart.
Because it has to go somewhere.
Exactly, and it creates a massive network of highly pressurized mediastinal and pleural venous collaterals.
It's like trying to repair a dam while the river is actively overflowing.
Yes. The blood from the upper body has spent years carving out these highly pressurized side channels all throughout the chest cavity.
So if you just open the chest and start dissecting through the dense pleural adhesions caused by years of CF infections,
You are going to rupture those pressurized side channels, and the surgical field will immediately flood. The risk of lethal, uncontrollable exsanguination during the pneumonectomy phase was deemed just far too high.
understandably. And leaving the PFO open during the transplant presents its own physiological nightmare, doesn't it?
Oh, absolutely. When the new lungs are implanted and reperfused, the sudden shifts in pulmonary vascular resistance and right-sided heart pressures could cause a massive right-to-left shunt through that PFO.
Leading to profound refractory hypoxia.
Exactly.
The surgical team recognized that performing a transplant under those conditions was a guaranteed mortality, so they couldn't do it all at once. How do you defuse the bomb before you attempt the transplant?
They utilized a meticulously planned, multi-stage approach, relying heavily on physiological sequencing.
Okay, what was step one?
Step 1. Close the PFO percutaneously in the cardiac cath lab. This secures the cardiac hemodynamics and completely eliminates the risk of a right-to-left shunt.
Okay, makes sense. And then
Step 2. Surgically bypass the SVC occlusion using an aortic homograft.
so they bypass the blockage, essentially reconnecting the upper body venous return directly to the right atrium.
Exactly. And by restoring a normal, low-resistance venous return pathway to the heart, they effectively decompressed and collapsed that dangerous, highly pressurized network of collateral veins in the mediastinum.
They essentially drain the overflowing reservoir,
Yes, they made it safe.
which finally makes the chest safe to open for the actual lung transplant.
Only after the patient recovered from the bypass and those collateral venous pressures normalized did they proceed to step 3, the bilateral lung transplant.
It is a brilliant testament to the reality that complex thoracic surgery is essentially high-stakes strategic staging.
Sometimes the best surgical maneuver is knowing exactly what not to do today so the patient can survive the definitive procedure tomorrow.
That is incredible clinical foresight. So let's summarize the core lessons for the medical learners listening. Based on these 50 challenging cases, modern thoracic surgery is a tightrope walk.
It really is.
It requires aggressive resection when oncologically necessary, innovative biomechanical reconstruction using titanium and advanced materials, and an unparalleled level of physiological strategy and staging to outsmart the patient's failing systems.
It anchors back to our very first thought. The textbook gives you the baseline anatomy, but the operating room requires split-second adaptation.
You have to be ready for anything.
You must respect the biomechanics of the chest wall, deeply understand the pressure dynamics of the diaphragm, and be entirely willing to stage complex physiological corrections to mitigate massive surgical risk.
To reinforce this clinical learning for the medical students, residents, and young professionals tuning in, it's time for our focus rule review exercise.
Let's see if they were paying attention.
Listener, I want you to imagine you are the surgical resident on call. A patient presents with a late-stage diaphragmatic hernia, and the CT imaging shows that the right pleural space is completely occupied by abdominal viscus. So, bowel and liver extending all the way to the pulmonary apex.
A very full chest.
Based on the physiological mechanics we just discussed today, what is the safest initial surgical approach, and why is a minimally invasive robotic method specifically contraindicated?
Take a second to visualize the pressure gradients and spatial mechanics.
Got it.
The answer, as we explored in case 14, is that a low lateral muscle-sparing thoracotomy is the preferred approach. And a robotic method is absolutely contraindicated because the herniated organs occupy the entire pleural cavity.
Exactly. Without the physical space necessary to safely introduce carbon dioxide insufflation to create a working environment, attempting to manipulate powerful, rigid robotic instruments carries an unacceptably high risk.
You'd risk perforating the pressurized bowel or lacerating the liver. So swallow your pride, respect the spatial reality, and open the chest safely. I love it.
I want to leave our listeners with a final provocative thought as they head back to the wards or their studies.
Oh, let's hear it.
We've seen how VATS, titanium 3D modeling, and robotic platforms are rapidly evolving. We've also explored how physiological criteria we once viewed as absolute contraindications, like high PaCO2 and emphysema, or massive collateral venous networks and cystic fibrosis, are being successfully dismantled through strategic staging and highly targeted patient selection.
Right.
As our technology and biological engineering continue to advance at this pace, will the concept of an absolute contraindication eventually disappear from medical textbooks entirely? Will we reach a point where every anatomical or physiological barrier is simply viewed as a staging problem waiting to be solved?
That is a fascinating question to mull over. The imaging might still show a murky, complicated, high-risk picture, but the structural and physiological tools we have to navigate those muddy waters are getting sharper every single day.
They really are.
Keep questioning the consensus, look past the textbook algorithms, and be ready to adapt the moment you step under those operating room lights. Thank you for joining us, and we'll see you on the next Deep Dive.